Good morning, everyone. Nice to be here. My name is Dave Greenwald. I'm from the Division of Gastroenterology. For medical grand rounds today, it's my pleasure to introduce a new member of the GI faculty. He's been with us for about a year, a little over a year now, Dr. Chris Chow. Chris has made a huge impact in our division very, very quickly with a really good nature, an incredible zeal for teaching, and sort of a thirst for expanding our capabilities in the areas where we could have used some expansion. So one of those is celiac disease. Chris is in the process of really energizing a celiac disease program at Mount Sinai. He completed his internal medicine residency and GI fellowship in Philadelphia at Jefferson. Hopefully not an Eagles fan, but we won't hold that against him. Where he developed this interest that I talked about in celiac disease and in other things as well. He's since presented and published on this topic, including recognition from the American College of Gastroenterology at its most recent meeting. And as I said, you will see more and more from Chris as you hear about the Mount Sinai Celiac program and all that it entails. So Chris was simply asked to talk today to us about updates in celiac disease. I've heard pieces of this before. It's brilliant. So you're on your way, Chris. Thank you.
Thank you so much for the introduction. For those that don't know me, my name is Chris. I'm a relatively new faculty here at Mount Sinai. I started about a year ago, and I live dangerously close to the hospital, like 1 block away. So if you ever see me at the halal cart on 102nd and Madison, feel free to say hi. But I do have a clinical interest in celiac disease, and that's something I really wanted to talk to you guys about today. It's something I'm pretty passionate about and excited to share with you. So without any delay, I have no disclosures. A couple of the objectives that I wanted to highlight for you guys today was, initially just to explain the basics of celiac disease with regards to clinical presentation, diagnosis, and management, but then really to get, delve into the weeds a little bit more with regards to updates and, what's been new in this field and, where this field is trending. And so I think some of the people that have heard my talk before know about this, so I'll ask you not to respond. But I was hoping to do a little exercise with you during this presentation, and it's kind of a Where's Waldo, but we're going to try to find the gluten in a couple different pictures, and we'll do that throughout this presentation. So the first one here is where is gluten? Oh, and by the way, so every time you see that little symbol on the right, it'll just open up the room for input. So I'll let this one sit for a little bit. Feel free to shout out any answers, and we'll kind of go over it. And if you don't have answers, I'll just kind of tell you guys as well. So in terms of where gluten is right here, it's a bit of a trick question. So 100% or pure oats do not contain gluten. Okay, gluten is present in barley, rye, wheat, but not in 100% oats. Now, with that being said, the processing of oats really needs to be examined further because a lot of the gluten exposure that our patients have are due to the processing of certain types of foods. What about here? So if you thought that the answer was Play-Doh itself, you're absolutely correct. So it's, the Play-Doh is actually one of a pretty common reason for gluten exposure. And I'll give you an anecdote. So we had someone when I was training who was a kindergarten teacher. And, they came in, they were very religious about their, gluten-free diet, but they obviously, were playing with Play-Doh with their kids. And by touching that Play-Doh and then touching their mouth, that was actually enough exposure to keep their serologies elevated. And so that's just an anecdote that I just wanted to throw out. All right, so in terms of history, I promise this is relevant to you because there's some Mount Sinai tidbits in here for future Jeopardy. So as we know, the field of celiac disease, I think, has really exploded over the past 20 or 30 years. But it's always been around. And, we see evidence of this starting in 1 AD. There was an archaeologic dig in Italy where they found the skeleton of a young female, young woman who had the signs of celiac disease, malabsorption, Her bones were positive for HLA-DQ 2.5, and it was thought that, there was celiac disease, way back then. Coming more to, modern times, Dr. Samuel G. is the father of celiac disease, which sounds a little bit creepy, but he's the father of modern celiac disease. This was in 1887. He characterized this disease process. Then here is the Mount Sinai tidbit. So Dr. Sidney Haas, I think was born in Chicago, but then he came to New York for training. He, I think, went to NYU for medical school, which is irrelevant. But then he came to Mount Sinai as an intern, and he, I think, later went on to Columbia. But what he did, his role in the management of celiac disease was he was able to identify a potential treatment, and it was very interesting. He thought the treatment for celiac disease was a banana diet, which, there's no gluten in banana, so it does make sense from that standpoint. So he was referred patients from all across the country, and they all came in, and these were, pediatric patients, and they came in, they started this banana diet, and they all felt better. The only downside was when they left New York City and they went back to their homes and they, resumed their own diet, the disease kind of reflared. I think a very interesting question that we have is, for inflammatory bowel disease, we don't have a diet. But in celiac disease, we found the trigger. We found gluten and gliadin as a trigger for celiac disease. And so the question is, how did we find this? And it was very interesting. As with all things in medicine, I think it was almost found on accident. During World War II, William Dyke theorized that wheat was the trigger for celiac disease, and he found this because of the Dutch famine. So in that time, the Netherlands did not have any bread. And during this period of time, the mortality rates for celiac disease decreased to 0. And so it was through that observation that he thought that wheat was a potential trigger for celiac disease, and that's kind of where we are right now. Of course, over the past 20 or 30 years, we've developed potential drugs for celiac disease, and that's a topic we'll talk about at the end of this lecture. And that's kind of where we are right now. So in terms of epidemiology, the global prevalence has always been a bit surprising to me. It's higher than I've thought, and it's about 1.4% of the global population. They have some form of celiac disease. There's variance among countries. There's variance in the country itself. So for example, in India, the northern regions have a higher prevalence of celiac disease compared to the southern regions. And why is that? It's theorized that it could potentially be due to diet, a change in diet between the different geographic locations, or potentially there's a genetic component to that as well. In addition to that, the incidence of celiac disease over the past 20 years has been rising as well. Now, it's not because celiac disease is increasing and, there's not more celiac disease, but we are noticing that people are getting better at diagnosing it at an earlier stage. And so there was a study done in Wyoming where the percent of undiagnosed celiac disease about 30 years ago was about 95%. That number has come down to 83%. But that still means that there's a good population or a good proportion of our patients that have celiac disease that have never been diagnosed. I think what we're trending towards is that, the diagnosis of celiac disease has picked up. But in addition, if we take a look at the Google searches for, dietary fabs over the past 20 years, we'll see that the gluten-free diet has really picked up in popularity, for better or worse. Since 2004, we see that the low carbohydrate diet has come down. And now gluten-free diet is, this popular term. Everyone wants to be on a gluten-free diet, for better or worse. And we'll talk about the implications of that going forward. So in terms of clinical presentation, this is an iceberg. You'll see this in most textbooks of the 3 stages of celiac disease. There is the latent or possible celiac disease. These are patients that are at risk. So they have the genetics for it, but they don't have any mucosal damage. They have the positive serologies. They don't have mucosal damage. And then moving up from that, you have patients with mucosal damage and then patients with actual symptoms. I had a professor during my fellowship that told me, and this is going to date him a little bit, but he told me that back in his day, you could identify a patient with celiac disease in the pediatric population by just looking at them in the waiting area. These were patients that were frail. These were patients that were a lot paler because of the iron deficiency and with abdominal distension. So these are the classic symptoms of celiac disease, but we don't see that as much anymore, because we're getting better at diagnosis. So we have patients in the NFL. I promise he's not an Eagles player. And we have patients in the Olympics, and they're thriving with the diagnosis of celiac disease. What do we see these days? It's not necessarily that classic presentation. Sure, we can see GI symptoms, but there are other things that will alert us to a diagnosis of celiac disease. Iron deficiency. 40% of these patients have elevated LFTs on presentation. Osteopenia or osteoporosis, dermatitis, and then very interestingly, and I know my fellows know this because I've told them this multiple times, there's a very interesting actually diagnosis called Gobi syndrome, which is a combination of celiac disease, occipital calcification, and seizures. And so these seizures are only seen in patients with celiac disease, and they don't respond to any treatment except for a gluten-free diet. And it's unclear why this has happened, but it's been documented in literature quite a few times already, usually in the pediatric population. Very briefly, I wanted to go over pathophysiology with you because I think that's always pretty important. Let me see, do I have a mouse? I do. So let's assume that this is the small intestine here. And this is the lumen, down here is the lamina propria. We have patients that consume gluten, which we know is the trigger for celiac disease. This gluten is then digested into gliadin particles, which are crossing the membrane these gliadin particles are crossing into the lamina propria. They're then deaminated by TTG, which is a very important thing to know. And then after deamination, they're presented to these APC cells. Now, in the presence of the positive genetics, so HLA-DQ2 or 8, the APC cell will then present this deaminated gliadin to a naive T cell, and it'll form two responses. One is the inflammatory response we see, that's responsible for many of the symptoms of our patients, and the other is the humoral response. This presents, or what happens with the humoral response is patients will then develop an anti-gliadin antibody or a TTG antibody, endomesial antibody, and these are things that we test for actively. Oh, sorry, wrong direction of the arrow. And what happens when we have this inflammatory response is we see a change in the mucosa, and that's what we look at on our biopsies. We see that the villi shrink, they get smaller. We see that there are more intraepithelial lymphocytes because there's increased inflammation in the area. And then due to this, we've actually come up with and by we, I mean the Celiac Society, not myself. People have come up with a classification for celiac disease to really classify how severe the disease process is. And it looks at, again, the villi and the intraepithelial lymphocytes. So taking a break, here is another picture for Where's Gluten? I think this was taken from a medical drama, though I don't know the show. And if you correctly identified these medications in the bottom right corner, then congratulations. Because medication can sometimes contain gluten. I'll give you a full disclosure here. This is something that was presented at the most recent celiac disease meeting. I frantically took notes, and I'm going to represent it back to you. Okay, so this is not my own math, but this is what was presented. The first question is there gluten in medication? And the answer is yes. There was a study done in 1994. About 71% of medications contain gluten. The second question is that gluten enough for celiac disease to be triggered? And so the way we are able to figure this out is the tolerated amount of gluten a day is 10 milligrams. So just keep that in mind. And we have to make a couple assumptions here. The first is most ingredients in medication are gluten-free. But what contains gluten? It's the wheat starch. So it's the fillers, the binders, or the disintegrants, okay? And so wheat starch is about 0.01% gluten. So let's do some math here. Let's assume that our patient takes 5 medications a day, which might honestly be on the low side for a lot of our Sinai patients. But let's assume they take this 3 times a day, so 15 medications in a day. And let's assume the medication is entirely wheat starch, so the gluten-containing portion of the medication. That's about 1,500 milligrams of wheat starch in a day, which corresponds to about 0.15 milligrams of gluten, which is far less than the clinically tolerated amount of gluten. So if a patient ever asks you about their medication, to the best of our knowledge and to the best of our estimation, it is safe for them to take. So don't tell them to stop their medication. In terms of diagnostic pathway, I wanted to present the most recent ACG guidelines. I'm not going to go over all of this with you. We'll go step by step. But the first, real decision step when we make a diagnosis for celiac disease is asking our patients, is the patient gluten-free or not? Are they on a gluten-containing diet, or are they on a gluten-free diet? I just laid out a couple things that contain gluten. And then if you actually look at the Mount Sinai order set, there are two orders that are associated with the diagnosis of celiac disease. One is the IgA with reflex testing, and the other is the celiac disease panel. In my opinion, and this is a very personalized opinion, I prefer the initial test, and I'll tell you why. So the celiac disease panel tests for TTG-IgA, but it also tests for anti-gliadin antibody. It also tests for anti-endomysial antibody. And so why is that a good or bad thing? Well, let's take a look at the accuracy of these tests, specifically of the anti-gliadin antibody, which is so frequently tested for in that celiac disease panel. What we're looking for is if the disease is, or if the test is positive, how likely is it for a patient to actually have that disease? And so I've gotten a lot of referrals for a positive anti-gliadin, or the AGA antibody, and we'll notice that the positive predictive value here is quite low. It's 18%. What that tells us is if a patient has a positive anti-gliadin antibody, the chances of them having celiac disease are 18%. Let's compare that to a TTG-IgA, which is better. It's at 72%, and then the anti-endomysial antibody, which is considered the gold standard for celiac disease, at 83%. Keep in mind the negative predictive value for these tests, 99% for anti-endomysial antibody, 99% for anti-TTG. So if they came into my office with a positive AGA, but a negative anti-TTG, a negative anti-endomysial antibody, it's quite likely they probably don't have celiac disease. The other one that I wanted to draw your attention to was the anti-DGP. This is an IgG test, and we use this for patients with IgA deficiency. So, whenever a patient comes, I order this celiac disease antibody test, and I always look at their total IgA number, because if that is low, then your TTG IgA is not going to be accurate. In that case, I think our lab actually automatically reflexes to the DGP IgG level. So what if they're on a gluten-free diet? Then what do? We actually would check genetics first, and the reason for that is actually to rule out disease. So, in a room full of people here, about 40% of us will carry positive celiac genetics. It doesn't mean that we all have celiac disease. It just means that we have positive celiac genetics, and that we're potentially at risk for developing celiac disease. Of the 40% here, only 5% will actually have celiac disease. It's necessary to have an HLA-DQ2 or 8 for celiac disease, but having a positive genetics does not necessitate celiac disease. And so if someone came in on a gluten-free diet and I check their HLA-DQ2 and 8 and it's positive, we can't really say much, but if it's negative, we can rule out disease. And whenever we check, these genetics, it's not very black and white. It's not just positive or negative. We'll get all these alleles, and I just wanted to kind of demonstrate what that actually indicates. So there was a study done in 2009, and it compared the different types of alleles to anti-endomysial antibody positivity, which is our gold standard. And even patients that were DQ2 homozygous had about a 28% chance of actually having celiac disease. If we go farther down, like a DQ 2.2 over here on this right side with another low-risk allele, while that may be positive, portends to a 0.68% of celiac disease. And if you recall, the prevalence of celiac disease in the US or in the world is 1.4%. So, I think we have to be careful with what we consider to be a positive genetics and what a negative genetics are, because I think the probability of having celiac disease varies wildly depending on the alleles. Let's assume their genetics came back positive. Then what do? Then we'd want to challenge them with gluten. We want to put them on an 8-week challenge of gluten, and then rebiopsy and recheck serologies. What does that kind of look like for a patient if they ask you? It's about 1 or 2 slices of bread a day, about half a cup of pasta, about 2 to 3 cookies, or about 1 cup of cereal. So not too much, but a lot of these patients are a little bit hesitant to do so because it can trigger symptoms for them. I think one thing that I wanted to take a little bit of time to talk about was the role of endoscopic biopsies. And this has been something that's been discussed quite a bit at very recent meetings. And it's a really big topic of debate. So I'll give you the data behind, what's been going on, and I'll let you make your own, opinions and judgment about this. So duodenal biopsies have been a central part in the diagnosis of celiac disease. We need positive serology, positive biopsies to establish the diagnosis. Believe it or not, traditionally, we actually required 3 biopsies, 1 biopsy on a gluten-containing diet, 1 biopsy on a gluten-free diet, and then a 3rd biopsy on a gluten challenge. We don't do that anymore. So right now, we just do one set of biopsies. But a lot of people these days have been really questioning the need for the biopsy, okay? And this stems from our pediatric guidelines. Our pediatric guidelines state that if someone has a very high TTG-IgA, and they have a positive anti-endomysial antibody, then there's no need for a biopsy. They think that that's enough for a diagnosis of celiac disease. And it makes sense in the pediatric population because you don't want to put all these children through, unnecessary biopsies. But the question was now brought to the adult population. Is that enough for an adult, to say that someone over the age of 18 has celiac disease? And so we look at the data behind this. Truth be told, there's not a lot of data behind this, and that's one of the primary concerns. There was one study in 2021, and it looked at 145 patients with a 10-fold increase in TTG-IgA and anti-endomysial antibody positivity, and this is what it shows. So most of these patients were found to be MARSH3, and there's a positive predictive value of 95%, meaning for patients with a 10-fold increase in their TTG and a positive anti-endomysial antibody, there's a 95% chance they have celiac disease. Sounds great. So the case against biopsy was made. There's a high positive predictive value. You don't need an endoscopy, and we already have guidelines in place for a pediatric population. It's the case for a biopsy. So the case for a biopsy is this comes from one study of 145 patients. Are we ready to use that one study to change guidelines? And the second concern here is the positive predictive value is 95%, meaning in 20 patients, 19 will have celiac disease. But what we're kind of saying is there is that one patient out of every 20 that we're going to tell them has to be on a gluten-free diet for the rest of their life, and they don't actually have celiac disease. Is that a risk that we're willing to take? And I don't have an answer for that, but I'll just leave it, I'll ask you guys and I'll leave it up to the room. The third concern here is there's a lack of a baseline endoscopy. So we want to see improvement of mucosal healing once someone's on a gluten-free diet. We don't get to see if there's any mucosal healing if we don't have a baseline endoscopy. And so this has been the primary argument back and forth over the past 2 years at most recent GI meetings. And I do think that a large part of figuring out what we need to do will rely on increased data to help drive our decision. But for now, the ACG still recommends multiple biopsies, so that's still part of our algorithm: 4 from the duodenum, 2 from the bulb. Okay, and so just to summarize the diagnosis portion, always ask about a gluten-free diet or gluten-containing diet when you're doing testing, and biopsies are still recommended. All right, so differential. What mimics celiac disease, and this is something I'm excited to talk about. We have wheat allergy, that's more of an IgE-mediated reaction. We have non-celiac gluten sensitivity, which is patients that believe that they react to gluten when their testing is negative, and then we have IBS-like syndromes. There was a study done in 2018. I thought this was a fantastic study. These are patients that were negative for celiac serologies. They did not have celiac disease, and they were given 3 types of bars. One was a placebo bar, one was a gluten bar, and one was a fructan bar. And then symptoms, patients' symptom scores were measured. And as we can see, compared to placebo, gluten actually decreased their symptoms. It was actually fructans that increased their symptoms. And so, a lot of our low FODMAP diets, are, low fructan diets as well. And so, that really leads to the question of, what non-celiac gluten sensitivity is, and if it perhaps could be a misunderstanding for patients themselves. I'll bring this up because I was taking a look over, celebrities that have celiac disease, and we see that Djokovic says that he has celiac disease. And so I actually went on to ESPN, and this is the article they published. And I'll just highlight it. It's on the bottom right here. So Djokovic says that he learned that he had a celiac allergy. First of all, that's not true. That's not a thing. Which affects roughly 6% of the population. Also not true. And it's interesting how he was diagnosed with celiac disease. So he actually had a doctor come to him, and the diagnosis was based off an arm raise test. And so for those of you that don't know, what he did was he put his arm in front of him, and someone would push down on his arm, and he would feel the resistance, and he would feel how strong he was. And then a doctor would put a piece of bread in front of his stomach. And then they would repeat that resistance testing. And he felt that the resistance decreased when a piece of bread was placed in front of his stomach. And so that is how he was diagnosed with celiac disease. But when we take a look at his actual win record, since he's been gluten-free, we see that he's been much more successful on a gluten-free diet. So who are we to tell him what to do? All right, so we'll go on to management. A common question right now is, what is our end goal for management? What is our end goal? So in patients with inflammatory bowel disease, we target deep remission. We want histologic improvement. We want symptom improvement. We want serologic improvement. What about in celiac disease? What are we targeting? So the first question we really have to ask ourselves is there a difference? Is there a difference between our symptoms, our serology, and our biopsies? And so we look at a study from 2010 in the Red Journal, and it stated that there is a difference. There's a poor correlation between our blood testing and our biopsies. In about 241 patients on a gluten-free diet, about 82% noted an improvement in serology. However, when we take a look at biopsies after 2 years, only 34% improved. After 5 years, only 66% improved. A median time to improve mucosal recovery was about 3.8 years. This is compared to serologies improving within weeks to months. So does that matter? And so we'll take a look over literature again. What is the significance of mucosal healing? And a lot of these studies were published at Columbia by Dr. Lebwohl and Peter Green, who are, the fathers of celiac disease modern time. And so they looked at the risk of not having, or a lack of mucosal healing, and what they found was there was a hazard ratio of 2.8 for lymphoproliferative malignancy, so it does matter. There's also an increased risk for hip fracture, about 1.67, so it does matter. When they looked at mucosal healing in terms of serious infection, mortality, ischemic heart disease, these were not statistically significant, but they trended towards, a requirement for mucosal healing, and there were really no adverse, there was no influence on the adverse outcomes of pregnancy. So what we see here is that we really should care about mucosal healing. And so that should be the end goal rather than just symptom improvement. And this is the proposed monitoring algorithm for patients with celiac disease. As you see, one of the major things that were included in this algorithm are that we should be performing a repeat biopsy after about 2 years' time to make sure that the mucosa has actually healed. A couple quick things here. So gluten immunogenic peptides, I would kind of describe, these are pretty new, I would describe them as almost like the hemoglobin A1C of diabetes for celiac disease. This is a urine test, and these peptides are resistant to GI digestion, and so it can look and quantify the amount of gluten that's in someone's system through urine testing. And it seems, this was first studied in 2017, there's not been too much movement on this, but it seems to be correlated pretty well with severe Marsh classification and also serologies. I think the concern right now is we don't have a standardized way of checking. We don't know what it means if it's positive, like has the patient taken gluten within the past week, within the past month? We don't know. We don't know when to check for it. Should they be checking after breakfast, on an empty stomach? These are questions that we don't know, and that's why it's still not widespread. But I just wanted to introduce you to this concept because I think you will be hearing about it a lot more in the upcoming years. The second is gluten monitoring devices. So these are the NEMA sensors, and they were developed in 1991. And what you do is you place a little bit of your food into the sensor, and it'll tell you if there's gluten found or not. The take-home here is NEMA sensors are overly sensitive, meaning they will tell you that there is gluten in perhaps foods that don't meet the threshold for gluten containing in our vocabulary. And so they are overly restrictive for patients, and that actually creates, quite a bit of anxiety for patients. So because of that, we don't recommend the use of gluten-containing devices, or I'm sorry, gluten detection devices at this time. These are my clinical pearls that I just kind of, thought of in terms of the diagnosis of celiac disease. Whenever we diagnose someone, of course, we want to send them to a dietitian. We have a new dietitian who specializes in celiac disease. Her name is Devora. We check serologies, we check their vitamin levels, we want to make sure they're vaccinated, pneumococcal vaccine, and then there's preventative stuff too. We want to make sure that their bone health is good, just with their vitamin deficiencies, and we want to screen first-degree relatives. Again, we check serologies every couple months until they've normalized, and then we do want to repeat an endoscopy at 2 years' time. All right, so back to our picture here. We're going to assume that we are Ted Mosby, and for those of you that have never seen the show, I'm not going to say who the other person is, but let's assume you're Ted Mosby, and I'm trying to ask you to find where the gluten is. Not the raindrops. Oh, makeup. Yes. So makeup and kissing. Those are two of the things. So gluten in dating. This is a question that my patient's asking me, and the question is, should patients with celiac disease only date patients with celiac disease? And the answer is absolutely not. But is there a risk of contamination when when someone is intimate with their partner and that partner is on a gluten-containing diet? So for that, we have to look at more data. There is no data on gluten and kissing, but there is data on peanut allergens, and that's the best that we'll do for now. That will do. So in a study of 38 individuals, they ingested 2 tablespoons of peanut butter, and then there was a detection device to check how long that peanut butter would stay in their mouth. After 1 hour, about 80% of that population had no detectable levels of peanut. After several hours, I don't know why they said several hours, but the paper said several hours, 100% had no detectable level of peanuts. So assuming that this applies for gluten, then we can consider that it's fairly safe to be intimate with someone without celiac disease, but we would still recommend using, separate utensils, having, their partner brush their teeth, which should go without saying, after ingesting gluten. So now brings us to non-responsive celiac disease. I promise we're like 2/3 of the way done, so thanks for sticking with me. So non-responsive celiac disease, what is this? So essentially, this is defined as continued symptoms. So let's assume that you have someone that was diagnosed with celiac disease, and after 6 to 12 months, they still had either symptoms or elevated serology or mucosal damage. And believe it or not, about 30 to 50% of patients we diagnose with celiac disease will have non-responsive disease. And so we're wondering, why is that? What do we do now? What's the next step? And so if we take a look at a couple of the studies, by far the most common reason for non-responsive celiac disease is gluten contamination. So they're still on a gluten-containing diet inadvertently. And so that's the most common reason. But there are other reasons or other etiologies that we tend to look for. One is microscopic colitis, and that would require a colonoscopy with biopsies. And then other etiologies include SIBO, small intestinal bacterial overgrowth, pancreatic insufficiency, IBS, or refractory celiac disease. So what is refractory celiac disease? This is different from non-responsive. Refractory celiac disease is persistent symptoms with villus atrophy despite a year on a strict gluten-free diet. This is made as a diagnosis of exclusion. So you exclude all of the other processes that we talked about. And typically, patients with refractory celiac disease have a negative serology. So their serologies are normal, but they still have symptoms and they still have villus atrophy. Why do we care about this? We care about this because the mortality is very significant. In a study in 2009, patients with type 1 refractory celiac disease had a 5-year survival rate of 93% and a lymphoma rate, enteropathy-associated T-cell lymphoma rate of 14%. In type 2 refractory celiac disease, there's a 5-year survival rate of 44% and a lymphoma rate of 33%. What's the difference between type 1 and type 2? On immunohistochemical staining, type 2 has abnormal CD3 and CD8 cells. But anyone that has refractory celiac disease, especially type 2, as we can see, has a pretty poor prognosis. So what do we do for these patients? In type 1 refractory celiac disease, we use open capsule budesonide or prednisone. Second line includes azathioprine or 6-mercaptopurine. And then for type 2 disease, we still try this budesonide, but then we have to consider other options as well. Unfortunately, there's not great data on this because it's so rare, but something that we have to discuss. When I was, recently in Rochester, Minnesota, there was someone who was very well known in the field of celiac disease, and he told me that, by using open capsule budesonide for both of these types, if taken in a certain way, could mitigate that mortality risk or could lower that mortality risk. So clinical pearls, you want to first confirm that the initial diagnosis of celiac disease was correct, and then afterwards evaluate for other causes of symptoms. If those are all ruled out, then you really have to consider type 1 or type 2 refractory celiac disease. All right, so last like 5 or 6 minutes, I wanted to talk to you about some of the exciting updates in celiac disease, okay? And really, I wanted to talk to you about the management. So this was a study that we did that looked at the socioeconomic disparities in celiac disease. We see that patients at a higher socioeconomic status tended to do better. I think that's the take home. But the reason for that is because gluten-free diet can be pretty expensive. And so sometimes we think that we need a better method of treating celiac disease than just gluten. In patients with IBD, we have many, many medications, and everyone's looking for a diet. And in celiac disease, it's the other way around, where we have a diet, but we're looking for a medication. And so, in terms of advancements in celiac disease, we look at a couple different places in this pathophysiology where we might be able to make a difference. We have these gluten peptides. What if we were able to break that down a bit further? So we're not absorbing this gliadin. What if we're increasing the adhesiveness of these tight junctions so that the gliadin is not coming through into the lamina propria as well? Or what if we block the TTG? So these are all things that have been studied, and I don't want to take too much of your time here, but they have been pretty promising. I think the take home here is that for any celiac disease research, it's a little bit more complicated, especially for clinical trials. And the reason for that is all these patients are already well controlled, right? So when we do a prospective study, you can't really judge therapy if they're already well controlled. So what do you have to do? You have to actually put them on a gluten challenge again. So you have to actually re-trigger their disease process in order to see if a medication is helpful. And that's been really the limiting factor here, or limiting reagent to getting this research off the ground. It's very hard to convince patients who are well controlled to then have symptoms again. But this is what all of these studies are pretty much trying to replicate. These are patients that have celiac disease, they're well controlled, you gluten challenge them, and then you compare the medication to a placebo. We can see lattaglutenase here degrades these peptides before they could transit the small intestinal mucosa. This was done at Mayo Clinic, and it shows that it's fairly beneficial for the patient. We can see that compared to the placebo, the villus height to crypt depth ratio is improved, and we can see that there is a decreased amount of intraepithelial lymphocytes compared to placebo. So that's a great study, and that was done in 2022, and there's more that will come out in terms of that study. This is lorazepam, which is a tight junction regulator, and believe it or not, the lowest dose of this medication improves symptom scores the best. Unfortunately, this medication was discontinued for financial reasons. And then most recently, we have a transglutaminase 2 inhibitor, which also seems to be quite promising. None of these have passed phase 2 trials yet, and so there's still a little bit of ways to go, but I just wanted to introduce you to some of them. And I think the most exciting medication, at least in the past year, has been focused on restoring immune tolerance of gluten by targeting receptors on the liver. So essentially, patients after injection of this medication will not have that response to gliadin. So I think that's been really the most exciting medication that people have been talking about. So there are a whole slew of medications that we're certainly considering for celiac disease. The take home is right now we don't have any medications, and so we have to focus on a gluten-free diet. But then this is my plug, okay? We are trying to, create a celiac disease program or center here at Mount Sinai, and we're hoping to, be able to join, some of these clinical trials, and for that we need patients. So if you have anyone with celiac disease, if you have any questions or anything like that, we're establishing a little team here, and we're happy to see some of your patients. This is my contact information, and thanks so much for listening.
As promised, that was outstanding. Thanks, Chris. Really good. We learned a ton about Novak Djokovic. Kissing is bad, and somehow, all the other stuff you told us will be percolating around in our heads for a while. Does anyone have any questions here? And then I don't know how I see the Zoom ones. Jean-Fred first.
Thank you so much. Very nice. I still have many questions about the epidemiology of celiac. First one is that, where are the patients? According to your number, we should see as many patients with celiac disease as we can. Second, we should see much more complications. Lymphoma, I may have seen one cell. Second question about the epidemiology is a shift towards older age as diagnosis. So there is a big question about what's the environmental trigger that actually triggers the clinical symptoms. Someone who is genetically predisposed and has actually no symptoms until something is happening. And I'm very interested about the infectious hypothesis by yeast.
So that's a lot of questions. Maybe one at a time and repeat them so the Zoom people can hear them.
Sure. So the first question I think has to do with the epidemiology. I presented that 1.4% of the global population has celiac disease, but at least where we see it, we don't see that percentage. And I think that has to do a lot. And then you also mentioned the risk for lymphoma not being as high as the data shows. And I think that's all very accurate. I think partly what we have to look at is the incidence of celiac disease and the percentage of undiagnosed celiac disease. So we hypothesize that there's about 1.4% of the global population with celiac disease, but at the same time, looking at Wyoming data, 83% of the patients have not yet been diagnosed. And that could be because of a wide spectrum in terms of disease presentation and how symptoms present. So I do agree with you. I think in terms of this lymphoma, I've seen like one or two, while the data shows it's in 1%. And I think that may actually be part of the reason that while celiac disease is not completely diagnosed by the population, we're seeing perhaps the 10% of patients that have the most severe disease presentation, and of those 10% that we're actually diagnosing, perhaps that's the 1% of lymphoma risk. And with regards to your second question about why patients are presenting at an older age, I think that's a very interesting question and something that I would love to discuss with you further. I know that we had been talking about potential fungal triggers and stuff like that, and that's something that I think we need to certainly take a look at without spoiling it for the rest of the room, and something I'd love to continue talking to you about.
Since they're already starting to work on that together, actually, Dr. Kraft.
Really nice talk. I was debating about with the data that you showed about children versus adults, the utility of biopsy. And I guess I would ask, the testings both show, I think if I heard you correctly, 95% positive predictive value in both groups. So is the risk of biopsy just higher in children? Because in a sense, you're going to commit them to a gluten-free diet, and 1 out of 20 unless the risk of procedure isn't warranted, why would you not do biopsies in children?
I agree. I think based off the data, I would agree with your conclusions. Whenever we have a pediatric population that comes to age of 18 years old and they've never had a baseline endoscopy, we will do it. So we will gluten challenge them and we'll repeat the biopsy to really establish that diagnosis. I do think it really comes from European guidelines where they recommend not biopsying children. But again, we are putting about 1 in 20 kids on a gluten-free diet when they don't have the actual disease process. And that would be a lifelong, right. So while a positive predictive value of 95% sounds appealing, it really isn't good enough for what we're trying to do.
And I think we're still biopsying pretty much everybody right now. From Zoomland, what are your thoughts, this happens all the time, about a well-controlled celiac patient who ingests a small amount of gluten at a meal and immediately feels digestive symptoms? Does this make any sense?
Yeah, so from a pathophysiology standpoint, usually, for patients with celiac disease, these symptoms are not immediate, okay? So in patients with, perhaps like a wheat allergy or, perhaps, IBS, the symptoms may be a bit more immediate. But in celiac disease, it's not, patients don't present with worsening symptoms, especially after just one meal. It does take some more time. And so certainly these patients may have celiac disease, but they potentially may have a secondary factor in why they're having these symptoms.
Another one from Zoomland. What do you advise for patients with positive celiac antibodies, like a TTG, for example, and high-risk celiac genetics, who then have a normal endoscopy and biopsy, who may be in a preclinical phase and have other autoimmune diseases like type 1 diabetes?
I think in these patients, there is a spectrum. Let me just quickly go back here. So these patients are certainly at risk, especially if they have, other autoimmune diseases. Potentially they have positive serologies, but they don't have potentially they don't have mucosal lesions yet. We consider those as latent celiac or possible celiac disease. I will say that, mucosal changes can happen over time. So it's not that, assuming like at age 18, if they didn't have mucosal changes, it doesn't mean at age 45 they won't. So celiac disease is certainly on the table still, especially with patients with autoimmune conditions. It's just at that time they haven't had any changes to their histology yet. It doesn't mean that they will never have any changes.
And do you want to comment on any medications that might cause or mimic celiac disease?
Yeah, so of course. So in terms of villus atrophy, that's something that we're always thinking about. So the classic one is going to be angiotensin receptor blockers. So olmesartan is the big one. So anyone with, that's taking olmesartan with a negative celiac serology and villus atrophy, potentially may not have celiac disease. It may just be medication induced.
Right, so if you see that on some board type questions, pay attention. Yeah.
Yeah.
Really interesting. The clinical trials we showed are fascinating. Gluten-free diet takes care of symptoms.
Mm-hmm.
And so what is your sense of, is there a market? Is there you said some of them would have come to fruition. You wonder if the fact they couldn't get enough really investment to take it over the finish line because it's hard to find patients if they're already controlled. You could say, well, it's really hard to maintain gluten-free diet in your life. There could be some advantage to using meds. I'd love to take that.
Yeah, I think that's a great point. I think, with a gluten-free diet, again, most patients are very well controlled. And so, the diagnosis or the management of celiac disease is not, as emphasized in the pharmaceutical community as, some of our other medications. I do think that on a gluten-free diet, there are a couple limitations. Of course, for lifestyle, a lot of our patients will tell you they don't want to be on a gluten-free diet for the rest of their life. They would love to have something similar to, for example, like a lactase pill, for patients with lactose intolerance, where they're able to tolerate some gluten. And so for them, it makes a difference in their quality of life. And also with regards to costs, I think we're seeing that it's coming down a little bit, but, it's certainly more expensive compared to, a gluten-containing diet. All of that being said, I do wish that, we're able to, put more funding in celiac disease research. especially for, if there's an injection that will, modify the immunity of the patient towards gluten, and it potentially is, either an annual thing or a one-time thing. I think that'd be very promising for these patients.
One more from outside. So, sorry, I lost. So, can you speak about how often celiac family members who are then HLA positive at risk be screened for symptoms or serologies?
Yeah, I think that's a great question. So patients that have celiac disease, we always recommend their first-degree relatives to be screened. Believe it or not, the patients that are at highest risk for celiac disease, so let's assume person A has celiac disease, the highest risk individuals are their siblings. There's a 20% chance of their sibling having celiac disease. There's a 10% chance of their children having celiac disease. But we still recommend that everyone be screened. That's a first-degree relative.
John Fred?
Such as...
Other what?
Other concerns. I mean, outside lymphoma.
Oh, yeah, of course. So let me just pull it up right over here. Sorry. So, in terms of, I think we just have to think about, how celiac disease works. It creates bowel inflammation. It reduces the amount of absorption. So, malnutrition, I think, is a big one. In patients with, malnutrition, they are then at risk for osteoporosis, osteopenia, and that's why we recommend a DEXA scan for anyone in the adult population within a year of diagnosis. These patients also have hyposplenia. So they are at increased risk for pneumonia. That's why we always recommend a pneumococcal vaccine. Of course, they're at risk for skin findings, and then also elevated LFTs. So we've gotten a couple referrals for patients just from the hepatologist with elevated LFTs. We don't know exactly what causes that, whether it's toxins being more able to be absorbed into the GI tract and then to the liver as first pass metabolism. But patients with elevated LFTs are certainly something else that we see. As you can see here, some patients have increased psychosocial issues, anxiety, depression. That's irrespective of their actual disease diagnosis. And then also there's an increased risk of decreased fertility as well in patients with celiac disease.
I think the question also wanted to cover other cancers, like small bowel.
I'm sorry, I didn't hear you.
I thought you said concerns, not cancers, so go ahead.
Sure. So enteropathy-associated T-cell lymphoma is increased. There is a mild but not significant increased risk for stomach and colon cancer, but we're not really sure why because it doesn't affect the colon. But there is a mild but observed increased risk of that. And I don't think there's been a study on esophageal cancer, so that's a good question, but I don't know the answer to that. I do think it decreases some forms of extra-intestinal cancer, believe it or not. But again, the pathophysiology behind that is unclear.
And I'll bring up one more thing. So you mentioned Peter Green and some of the folks at Columbia who've been working on this. When I was up there, we picked up a ton of patients who had vitamin deficiencies from the neurology clinic. And you mentioned some interesting observations in that world. So how attuned do people seeing patients with general symptoms need to be to celiac disease and testing for it?
Thank you. And that's great for advertising for our program as well. I think you should be very in tune. So again, patients may not have symptoms. Those classic symptoms of celiac disease, we don't see as frequently as before. Patients that we should be, on the lookout for elevated LFTs for no other cause, vitamin deficiencies. Even, we'll see referrals from our dermatology colleagues for dermatitis herpetiformis, and then from the neurology or psychiatric clinic for, anxiety, depression, stuff like that. These are patients that we should really consider celiac disease in the diagnostic pathway for. Because again, the global prevalence is 1.4%, but 83% of this population is undiagnosed. So I think there's a lot that we can do to increase that diagnosis.
All right. Thank you very much, Chris, and thank you all.